अगेन बोल देती हूँ और क्या बोलूँ मैम.
Maybe they have not registered.
नहीं, उन्होंने वो लिख रहे हैं हमने रजिस्टर किया है पर वो फिर से रजिस्ट्रेशन मांग रहा है. टेक्निकल टीम, कैन यू हेल्प somehow?
अब मेल आईडी में जाके करना है, आई सपोज मेल आईडी में जाके जूम उस पे क्लिक करना है तो आ जा रहा है.
हाँ, मेरे साथ भी यही हुआ
मेल
है.
आईडी
मैं
में जो
वैसे
मैसेज
कर
आया हुआ
रही
है
थी
डॉक्टर
तो
अर्चना.
मेल आईडी में आके फिर आ जाता है.
हाँ, मेल
ऐसे
आईडी
नहीं
में
आ रहा,
आके
मेल आईडी में ही आके.
ओके.
और या वो उसमें जो आया हुआ है मेल में,
एक ने जूम ऐप ही डाउनलोड नहीं किया है.
हाँ, जूम ऐप तो डाउनलोडेड चाहिए ना उसमें, या फिर उससे ज्वाइन कर लेना मैम. फिर अगर डाउनलोडेड नहीं है तो.
पूनम आ गई? पूनम भी नहीं आई.
हाँ मैम, पूनम आ गई.
अच्छा
पूनम ने ज्वाइन कर लिया है मैम.
अच्छा अच्छा. पूनम लेफ्ट.
पूनम लेफ्ट.
इसमें आ रहा है ऊपर.
अच्छा मैम, मैं इधर आंसर दे रही थी ना. पता नहीं पूनम क्यों लेफ्ट फिर. पूनम you left. So ma'am, with your permission, Dr. Khurana, can we start now?
Yeah, sure.
So welcome all delegates. This is actually a FOXY initiative along with WHO, which is unique in its own perspective because it's talking about respectable abortion care. When the world is talking about just abortions, we are talking about respectable abortion care. We not only think about the safety of the patient, we also think about the dignity, we think about the respect of the patient. And with this, we are moving ahead, and we as Foxians are very proud to be the torch bearers of this special and unique program. And it is onus on us to bear the flagship globally. So we have 4 talks today, and congratulating and thanking Dr. Shanta Kumari, the president of FOXY, and her team to bring such a nice program, which will be talked about globally. And India is definitely one of the main countries who are taking it, who are taking it globally. So, to be a Foxian and an Indian, it's a part of pride with this program. So we are having 4 talks. In the first talk, we'll be talking about whatever the amendments have been done in 2021 in the previous MTP Act. And this is very important amendment because this talks about not only the safety but also the privacy of the patient, and is amended just to bring the services at a very large scale so that no female dies just because of they are not attended and they don't get a safe abortion service. Then in the second talk, we will be revising regarding the technical part, the technology, any changes, any updates, how safe abortion, especially in the first trimester, is to be done, the surgical and medical methods. Then in the third topic, Dr. Kanchan will be taking, and this is all about it, the respectable abortion care, the WHO Saver Toolkit, which will talk about and we should not ever lose the opportunity about talking about contraception and family planning whenever whenever a female comes to us who is seeking for an abortion. So with this, I think I will invite Dr. Ritu Tripathi for the first session, which will be about the amendments of the MTP Act. So Dr. Ritu, the stage is all yours.
Good evening, everyone. Just screen share कर रही हूँ. Is it okay for everyone? Is it visible?
Yet not shared. Yes.
Good evening, everyone. Today, I will tell you
You
about
go
the
on
medical.
slideshow.
Okay. Today, my topic is medical termination of pregnancy, Amendment 2021. In this particular section, we will take a closer look at what are the new laws and what are the change in the rules. Why this act we required? Because unsafe abortion in India leads to mortality, morbidity, and hamper women and girls' full participation. About 8% of the deaths are per year due to abortions, which is the third leading cause of MMR. Nearly 2 out of 3 abortions performed are deemed unsafe. Nearly half of the pregnancy-related deaths are in women and girls under 24 years. So, when is abortion is considered unsafe?
Ma'am, slides are not moving, ma'am.
Okay. Okay, I'll take network issue. Maybe some network issue because they are moving from my side.
Ma'am, after clicking the share screen, just you click the share tab.
Okay. Now it's okay. Hello, I'm audible. Am I audible?
Yes, yes, doctor.
Yes, you are audible.
Yes, Ritu, audible.
Now it is okay.
Your first slide is visible. Try to move.
Dr. Archana, can you do this?
Yes, I will share. You stop sharing. I will share your slides.
Okay. So we will take a closer look at what are the new laws and what are the changes in rules. Next. Why this act was required? Because unsafe abortion in India leads to mortality, morbidity, and hamper women and girls' full participation. About 8% of maternal death per year are due to abortions, which is third leading cause of MMR. Nearly 2 out of 3 of the abortions performed are deemed unsafe. Nearly half of the pregnancy-related deaths are in women and girls under 24 years. Next. Next, please. When is abortion considered safe? According to WHO, an abortion is considered safe if it is done by appropriate method and by the trained person. Beside this, appropriate place is also important. That place should be approved by the government. Next. Medical Termination of Pregnancy Amendment 2021 gives safe and comprehensive care mandated by law. This rule was accepted on 25 September 2021. All of us are well aware of it, but today I am here just to give you a proper overview of the change and what are the implication of these changes. So this is these. Now I'm going to tell you about the salient feature of Mtp Amendment 2021. First is modification in the requirement of the provider. As we know, in the previous act, opinion of one provider, that is registered medical practitioner, was required up to 12 weeks. And opinion of two providers were required for termination up to 12 to 20 weeks. In new act, opinion of one RMP is required up to 20 weeks and two RMPs up to 20 to 24 weeks. This is important because increase in number, this is why this is important, because it increases in the number of facilities, especially in the public sector like PSCs, eligible for service provision till 20 weeks. Next please. Okay. Second modification is एक slide पीछे एक modification है यहाँ. Second modification is for the vulnerable group of women. In previous act, MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant women. New act enhanced the upper gestational limit from 20 to 24 weeks for special vulnerable category of the women, and further enhancements of birth defects which are not compatible with life on medical board consents. This is important because it increases access to vulnerable women to safe and legal abortion services defined by rules. Committee includes violence victim, minors, among others. Next, please. Third modification for birth defects and congenital anomalies. The previous act had provision for termination of such pregnancy up to 20 weeks. In new act, upper gestational limit does not apply in case of the pregnancy with substantial fetal abnormalities diagnosed by a medical board. This is good because most of the cardiac anomalies are diagnosed after 20 weeks. So anything, if we know this is lethal, that can be terminated at any gestational age. Its potential outcome is very important because increase in the access to safe and legal abortion services for those who are presenting late beyond the legal limit for termination with substantial fetal anomalies diagnosed late. This modification is aimed to reduce unsafe abortion and the court cases. Next, please. Another very important aspect is modification related to the marital status. In previous act, the condition of failure of contraceptive was applicable for only married women or her husband. In view of the changing socio-culture profile, this amendment talks about the condition of failure of contraception to be extended for any women, married or unmarried, or her partner. This potential outcome is also important because it increases access to safe and legal abortion for any women irrespective of marital age, especially with upcoming change in legal age of marriage. And this is important advancement for increasing access to safe abortion. Thank you. Next. So again, a very important feature is insertion of new clause for strengthening privacy. The medical termination of pregnancy regulation 2003 mentioned that information should not be disclosed except under authority of law. The new insertion is name and other particulars of a woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law of the time being in force. Its potential outcome is increase in privacy and confidentiality of abortion seekers, increased demand, but needs to safeguard the right and dignity of the women and provide respectful, bias-free services, including counseling and contraception. So this law prioritizes confidentiality and the safety. Next. Now, about the rules of Mtp Amendment 2021. It defines special or vulnerable category of the women eligible for extended period for termination of pregnancy from 20 to 24 weeks. The norms for the registered medical practitioner whose opinion is required for termination of pregnancy at different gestational age group, and power and the function of the medical board formed from each state and mandated to provide timely based timely evidence-based decisions. Next please. So if we talk about the abortion beyond 20 weeks, this act is not a blanket that you can give to everyone. There are special categories who are considered to be vulnerable. And these categories are survivor of the sexual assault, rape, incest, women with pregnancy in humanitarian setting, disaster or emergency situation as declared by government, changes of marital status during the ongoing pregnancy, widowhood or divorce, women with physical disabilities as per criteria under the Disability Act, mentally ill women, including mental retardation, minors, and the fetal abnormalities that has substantial risk of being incompatible with life, or if the child was born, it will suffer from such physical and mental abnormality to be seriously handicapped. Next please. Now the norms for the RMPs. RMP defined in the old act as MBBS or more with any medical practitioner assisted in 25 cases of MTP, of which at least 5 done independently in a hospital, who has completed 6 months of house surgency in Obs and Gynae, who holds a postgraduate degree or diploma in Obs and Gynae, and who has experience of at least 1 year in the practice of Obs and Gynae. Under the is it back. Under the amendment rule 2021, an additional category of provider has been added for termination of up to 9 weeks with the medical method of abortion. It needs a RMP with experience in the practice of Obs and Gynae at any hospital for 3 months, or training with performance of 10 cases of MTP by medical method abortion under supervision of a RMP in a hospital established or maintained or training institute approved for this purpose by the government. Next please. In this act, the whole period of gestation is divided into 5 parts. Till 9, there are different norms for RMP for different gestational group. Till 9 weeks, then 9 to 12 weeks, and 9 weeks, 9 to 20 weeks, 9 to 12 weeks, 12 to 20 weeks, 20 to 24 weeks, and beyond 24 weeks. These are all the almost same requirement. So I'm not going through these slides. Next, please. Next. This is important because beyond it. This is important because beyond 20 weeks till 24 weeks, we need postgraduate degree or diploma. We need a practitioner who holds a postgraduate degree or diploma in Obs and Gynae, and a practitioner who has completed 6 months of house surgency in Obs and Gynae, and a practitioner who has experience at any hospital for a period not less than 1 year in the practice of Obs and Gynecology. Next, please. Beyond 24 weeks, experience and training requirement for RMPs, he or she should be postgraduate or diploma holder in Obs and Gynae, or a practitioner who has experience of 1 year in practice of Obs and Gynae. In this, we need a opinion of medical board also. So now about the medical board. Now I'm telling about the composition of medical board. Next slide, please. The medical board is composed of it includes 1 gynecologist, 1 pediatrician, and 1 radiologist. The head of department of Obs and Gynae of that institute may be chair of the board. It may have at least 1 women member and 1 member from the government hospital. A specialist from other department may be included as per requirement of the case. And if any member at the time of discussion will not available, then they can substitute another member by the chairman, recommended by the chairman. Next. Now the power of the medical board. It can allow or deny termination of pregnancy beyond 24 weeks of gestational only after due consideration and ensuring that the procedure would be safe for the women at that gestational age, or whether the fetal malformation has substantial risk of it being incompatible with life, or if the child, when born, would suffer from such physical or mental abnormality to be seriously handicapped. They can co-opt other specialists in the board and ask for any additional investigation if required for deciding on termination of pregnancy. Next slide, please. Now the function of the medical board. To examine the women and her reports who would approach for medical termination of pregnancy, provide the opinion of medical board in Form D with regard to the termination of pregnancy or rejection of request within 3 days of receiving the request for termination of pregnancy, to ensure that the termination procedure, when advised by the medical board, is carried out with all safety precautions, with appropriate counseling within 5 days, of the receipt of the request for medical termination of pregnancy. This is important because so we cannot delay the procedure and keep the gestational advance. Next slide. Next. So now in India, abortion is legal. Let us make it safe and respectful. Thank you.
Thank you so much for that beautiful overview, Ritu.
Well,
Now I will stop sharing. So any questions, if are there, please, you can write it down in the chat box, or we can directly ask in the last session.
डॉक्टर रितु
Dr. Ritu?
हाँ डॉक्टर
हाँ बोलो.
I have stopped sharing.
डॉक्टर रितु medical board will be made by the state government, or it will be of different hospitals?
Medical board is made by state government.
State government.
Actually, there are 178 state boards right now, but I don't think we have one in Uttarakhand, because otherwise we would have come to know about it. But the things are in the process of formation. So by that time, the state board is not there. We have to go through the legal procedures only. So as soon as the state board is formed, I think we will be informed about, and we will definitely let everyone know in the society. So
Another
next,
question. There's a question, ma'am, if fetal anomaly is detected after 24 weeks, medical board is still required for abortion? Yes, medical board is required for abortion. If you feel the baby is not good, you can give an application to the medical board, and he will decide. He will decide it. Decided the abortion should be done or not. And yes, we can abort a baby 24 weeks of gestation also.
After 24 weeks, any lethal anomaly, a baby having congenital malformation, which is the baby is not going to survive, and for that termination, the opinion of medical board is required after 24 weeks. Earlier, that patient was not eligible for medical termination of pregnancy, even if there was congenital malformation after 24 weeks. But now it is a new rule. It is there, but we need the approval of medical board.
there was one question, Ritu, which was asked before the session. So I said you will come to know in the session only.
Yes.
Only whether incomplete abortion, some forms to be filled up for that.
No. Hello.
Please repeat the question, Dr. Archana.
Should missed abortion and incomplete abortion and incomplete abortion, they should be reported, or any forms should be filled for that?
No, there is no form should be filled for the missed abortion or incomplete abortion.
But a record has to be kept. You should have a separate register for it, and preferably also attach the ultrasound report to it.
You can keep this record in your minor procedure only.
Yeah.
Yes, ultrasound report is needed for that also.
So now moving to the next session, which is about safe abortion updates in technology. No significant updates. We'll just go for a revision. And each of you might be knowing better or might be knowing equal to what I will be sharing now. So the session overview is about the existing guidelines. Just we have to go through the guidelines actually. And then how to assess before aborting a patient, what are the medical methods and what are the surgical methods. And WHO has actually done a lot of work globally, and these are few works of the WHO Health Organization which are being done, and you can get all of them at the WHO website. So from 2012 to 2019, a lot of work has been done. This is the roadmap to WHO safe abortion guidelines presently in the 2019, and right now this is about the adaptation which has been taken up by our country regarding the WHO guidelines. This has been discussed very well by Dr. Ritu. What are the amendments being done? So now we're coming to the guidelines, and there are three key areas in the management of abortion safely. First is pre-abortion care, then abortion, and then aftercare and follow-up after abortion. And we have to definitely talk to the patient about contraception and counsel about it. So how to help the patient in making a decision? First, we have to find out her medical history. Then we have to examine her physically. We will have to go for lab and other investigations if it is necessary, and if the availability of investigations is there. If the investigation part is not available, then we can go for a clinical and physical examination and go for an abortion. Then we have to discuss the contraceptive options also. After that, we have to let her know what methods are available, let the woman decide herself, and we have to just help her out how to make a decision. So if a woman chooses to have an abortion, she should be allowed to choose from the methods available, whatever they are appropriate for her, based on the duration of her pregnancy and her medical condition. So the pre-abortion assessment and counseling, we have already talked about it. We have to take a detailed history. We have to go for a physical and pelvic examination. We have to go for the lab and other investigations if needed, and decision making. So this is how we have to find out the gestational age. We all know very well that we have to know the LMP of the patient, and if her periods are irregular, then we cannot rely on LMP. We have to go for the physical examination. We can go for a pervaginal examination in the first trimester because uterus can be felt only after 12 weeks per abdominally, and then we can come to know about her gestation by palpating the fundal height also. We all know very well about it. I don't think we have to go into detail. And we have to consider the discrepancy between the LMP and the physical examination also. And wherever needed, we have to do an ultrasound to find out why the discrepancy is. The pre-abortion investigations, routine lab tests are not a prerequisite. Test that may be performed as according to the individual risk factors or what you find physically. If you see that the patient is pale, definitely go for a hemoglobin estimation. If you don't, if the pregnancy is not confirmed, then a pregnancy test has to be done. Blood group examination also should be done so that the negative blood group women can be provided with the Rh immunoglobulin. HIV testing and counseling. Then STI screening, you can do it at the time of pelvic examination. You can look for any genital ulcers or any discharge. Then other lab investigations as indicated by the medical history, like the kidney or the liver function test. One thing is to be noted is ultrasound is not a necessary tool unless to diagnose a pregnancy. If it is not certain, if you're suspecting an ectopic or a missed abortion, then definitely you can go for an ultrasound. The pre-abortion counseling, so it includes, you have to ask the patient, just don't do your work. You have to know why she wants to terminate the pregnancy, what is the reason behind terminating. And this is just to know so that you can give her the emotional support. You have to inform her that early abortion is safe, the importance of a trained provider performing the procedure for safety, because otherwise she will, today she will talk to you and tomorrow she will go to some other person who is not a trained provider and get an unsafe abortion done. So we have to tell her the importance of the safety of safe providing abortion. The available methods of abortion, what are the available methods, risk and warning signs associated with the abortion method. Without contraception, she can get pregnant as soon as 14 days after an abortion. Resumption of her normal activities, including the sexual intercourse, and any other follow-up care that is needed has to be talked about. The documents, definitely we need an informed written consent, decision to accept post-abortion contraceptive, whether she is ready or not. Even if she is not ready, she cannot be denied of providing the abortion services. She has to be provided abortion services even if she denies contraception. So what is the clinical management? WHO says you can provide medical management of abortion up to 12 weeks. But the government of India says that it can be given only up to 9 weeks. Here is a discrepancy between India and WHO guidelines. And till less than 12 weeks, the global recommendation by WHO is Mephibostone and Misoprostol. You can give Misoprostol only, or you can go for a vacuum aspiration. And if it is more than 12 weeks, you can again give Mephibostone or Misoprostol. You can go for Misoprostol only, or a dilatation and evacuation. What you not recommend here is a sharp curettage. So sharp curettage is not recommended unless until it is indicated. So this is a diagram showing abortion, which is up to 9 weeks only. We will be talking about it in the further slide also. Clinical management of abortion, medical methods, methods of first trimester, and then the surgical methods, which include the manual vacuum aspiration and electric vacuum aspiration. So we provide tablet Mephibostone and Misoprostol, and how do they act is Mephibostone is an anti-progestin which inhibits action of progesterone. It interferes with continuation of pregnancy. Initial oral dose of Mephibostone followed by Misoprostol, a prostaglandin even analog. And what does Misoprostol do? It causes cervical softening, uterine contractions, and then the expulsion of the products of contraception. The advantages of tablet Misoprostol: it is very safe, it is easily available. Then what? And can be easily given also. It can be given orally, it can be given sublingual, it can be given buccal, it can be given vaginally. So Misoprostol is something which is available everywhere. It can be easily given and safely given. So these are the advantages. And what are the protocols of giving Mephibostone and Misoprostol is, on day 1 when the patient comes to you, you give her Mephibostone 200 milligrams orally. And if the patient is Rh negative, you have to give an anti-D of 50 microgram, which is not easily available. So you can go for a 300 microgram anti-D. No harm in giving it. Then on day 3 after Mephibostone administration, up to 7 weeks, you have to give 400 micrograms of Misoprostol, which is 2 tablets of 200 microgram each, easily available. They can be given sublingual, buccal, vaginal, or oral. And if it is gestation is between 7 to 9 weeks, then 800 micrograms of Misoprostol is given, either sublingual, buccal, or vaginal. In addition, if the patient complains of vomiting, pain, then you can add analgesics in form of ibuprofen and an antiemetic. And then you have to offer contraception also at the same time, because these are the patients who are most receptive at this time. Then you ask the patient for a follow-up within day 15. You have to confirm and ensure completion of procedure. Then you have to offer contraception also if she was not ready to take contraception at that time. So now again, you can take the opportunity to offer her contraception. So what are the characteristics of different routes of Misoprostol administration for first abortion, trimester abortions? The route can be oral. Instructions for use is pills are swallowed, and this is recommended up to 7 weeks, that is 49 days for first trimester abortion. And side effects include diarrhea, nausea, fever, and chills. When it is given buccally, in the buccal cavity, pills are placed between the gums and cheek and swallowed after 30 minutes. More fever and chills are seen than the vaginal route. In the sublingual route, pills are placed under the tongue and swallowed after 30 minutes. Increased fever, chills, diarrhea, and vomiting compared to the vaginal route. But here it shows the fastest onset of action and highest plasma concentration levels. When given vaginally, the pills are placed in the vaginal fornices, deepest portion of the vagina, and the woman is instructed to lie down for 30 minutes. The only thing is the pill fragments may be available, may be visible, but vaginal route shows the lowest rate of side effects and so found the safest. Then buccal and sublingual routes, this is a diagrammatic representation showing the buccal where the buccal can be placed tablets and where the sublingual tablets can be placed. So these are the WHO drug regimens, dose schedule for medical abortion. When it is given in combination with Mephibostone, we have already talked about 200 milligram once given on the first day, and then we give WHO says 800 microgram buccal per vaginal or sublingual on day 3, and if you give Misoprostol only, then 800 microgram buccal per vaginal or sublingual. In the Indian guidelines, we say if it is less than 7 weeks, we can give 400 micrograms of Misoprostol if it is given along with Mephibostone, and 800 if it is given alone. Then vaginal bleeding for 2 weeks is normal after medical abortion. Such bleeding can last up to 45 days in some cases. But then you have to find out why this bleeding is occurring for 45 days. If it is normal, then it can do. So what is the provision of medical methods of abortion services? Services should be available at the primary care level with referral systems in places for all required higher level care, because medical method can be given anywhere, but then you have to refer the patient in case of any complications to a higher level. Additional services may need to be provided to individuals seeking medical abortion, counseling and testing for sexually transmitted infections, abuse support services, psychological or social services, other specialist health or medical services. We have to provide her iron tablets for anemia if needed, provide any necessary pain medications, and this thing is all about is you have to provide emotional support to the women who are seeking abortion services, because they are already having some trauma behind. Nobody goes for abortion just for the sake of fun. So we have to take care of the emotional part also. So what is the follow-up care? Routine follow-up not necessary. Following an uncomplicated medical abortion using Mephibostone and Misoprostol. A follow-up visit between 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, emotional support, or to address any medical concerns. A routine follow-up visit is recommended only in cases where medical abortion is done by Misoprostol alone. Here you have to have a follow-up to assess the success of abortion, because these are the cases where the failure rates are more compared to Mephibostone and Misoprostol together. The follow-up care includes assess woman's recovery and ask for any signs or symptoms of the ongoing pregnancy. Sometimes it does happen, the patient doesn't have any symptoms, but the pregnancy goes on. So you have to find out that whether the abortion has been completed or not. Review any available medical records and referral documents. Ask about any symptoms experienced since the procedure. Perform a focused physical examination for any complaints. And then assess woman's fertility goals and need for contraceptive services if not provided earlier. So this is a summary about medical management of abortion. Day 1, what to do is we do a physical and pelvic examination, confirm eligibility, whether it is up to 7 weeks or more. Then tablet Mephibostone is given 200 milligram orally, anti-D if the 50 microgram if she is Rh negative. You have to tell the woman, return for Misoprostol administration after 2 days. Contact, address and phone number of the facility center where she can go in case of any emergency, and record her experience of any side effect on the MMA card. 3% of women may expel completely with Mephibostone alone. We all must have experienced this. The patient comes to us and says, "Ma'am, hamara to ho gaya," but then you have to ask her to complete the dose of Misoprostol also. Second day visit, day 3, what to do? We have to give Misoprostol 400 micrograms sublingual, buccal, vaginal or oral. Then we have to observe her for 4 hours. You give analgesia in form of ibuprofen if she complains of pain. And then contraceptive options like barriers, hormonal methods, injectables, oral, they all have to be provided. You have to tell the woman that the mean period of bleeding is 8 to 13 days. Possible side effects include nausea, vomiting, diarrhea, headache, fever, and dizziness. Then report in case of excessive bleeding. If there's any pain in abdomen and fever, report if there's no bleeding within 24 hours after Misoprostol. So consider giving additional dose of Misoprostol, then you have to rule out ectopics also in this case. 75% of women abort within 4 to 6 hours after Misoprostol administration. The third visit is on day, before day 15, and what we do here is we do a pelvic examination to ensure the completion of abortion. Contraception options are again provided to her. Tell the woman about immediate return to fertility, because she might say कि अभी तो abortion हुआ है and अभी मुझे कुछ नहीं होने वाला है, but then again she might come with a pregnancy in the next cycle. So you have to tell her that she might return to fertility immediately within around 14 days after the abortion. So she has to take care about it. Report back if there are no periods within 6 weeks of completion of abortion process, because she might be continuing her pregnancy, and you have to abort before she goes beyond the period. Then USG only if examination does not confirm the completion of procedure, then an ultrasound is indicated. Side effects and complications include the nausea and vomiting and diarrhea. Might get infections, which can be confirmed by physical examination, and we can start antibiotics for it. Pain is the most common complication, but here we have to be respectful and non-judgmental while talking about pain to her. And we have to support her verbally. We have to give her adequate counseling. We have to support her in person. Then you can provide her with ibuprofen 400 milligrams. Persistent pain, if presents with failure to respond to the drugs for several hours, it warrants evaluation for other causes such as ectopic pregnancy, infection, or incomplete abortion. Action for failure or incomplete result of medical methods. When we see there's a failure of medical method, you can repeat or you can offer her with vacuum aspiration. If it is incomplete, then observe whether the bleeding is heavy or not. If it is heavy, then and it continues heavily, you can offer a surgical evacuation. If it is not very heavy, you can give her a repeat Misoprostol. And if the bleeding is resolved and uterus is of normal size, you can consider that the abortion is complete. If there is excessive bleeding per vagina, how to evaluate whether she is having excessive bleeding, PV? Bleeding more than her menstrual cycle, that is soaking 2 pads in 1 hour for 2 consecutive hours. If bleeding decreases over time, then routine care is provided. Just keep a watch for a vitals and bleeding per vagina and she can go home. And if she is bleeding heavily, then you have to watch for a vital signs. You have to you do a PV examination. If there are products of conception in the cervical canal, just go for a digital evacuation. The woman is stable and bleeding reduces, observe for some time, let her go. If continues, then a USG or an ultrasound is indicated. If it shows minimal decidual bits, just wait and watch. If it shows products of conception and she is stable, you can give her another dose of Misoprostol. And if the woman is not stable, go for vacuum aspiration. If you ultrasound says the continuation of pregnancy, then again you will have to offer her vacuum aspiration. Recording and reporting of MMA. Since medical method of abortion come under the purview of MTP Act, the documentation is similar to that required for the vacuum aspiration procedure. It is mandatory to fill the following forms. That is Form C, which is the consent form. Form 1 about the RFP opinion. Form 2, monthly reporting form, which is to send to the district authorities. Form 3, then admission register for case records. Methods of first trimester, surgical methods. So we'll be talking about the surgical methods now. We are just talking about the first trimester. Vacuum aspiration is the recommended technique for surgical abortion for pregnancies up to 12 weeks. WHO recommends manual vacuum aspiration as the safest method, and the procedure should not be routinely completed by sharp curettage. Vacuum aspiration methods, procedure of abortion performed is same regardless of the type of vacuum used. That is, you might be using manual or an elliptical, the procedure is same. In the manual vacuum aspiration, held aspirator used to generate vacuum. The aspirator is attached to the cannula of 4 to 12 mm in diameter according to the week of gestation. Cannula can be used in multiple settings, including those without electricity. And easy grip cannula size corresponds with the week of gestation. Like if you are using if the gestation is of 8 weeks, use a 8 mm cannula. If the gestation is of 10 weeks, you can use a 10 mm cannula. So electric vacuum aspiration, we all have this machine with us. An electric pump is used to generate vacuum and can accommodate cannula of manual vacuum aspiration with correct size tubing. Cervical priming has a role, and I think it does reduces the complication, especially perforation. So must be considered for women with a pregnancy of any gestational age to prepare cervix and to make it soft and easy to dilate. Recommended methods for cervical preparation before surgical abortion in first trimester are oral Mephibostone, which should be given 24 to 48 hours in advance, 200 milligrams. or you can give her Misoprostol 400 microgram, which can be administered both sublingually or vaginally almost 3 hours prior to the procedure. Laminaria, we don't get laminaria tents here and then nowadays, but laminaria has been used to be placed intracervically 6 to 24 hours prior to the procedure and works as a cervical dilator. The pain management for vacuum aspiration procedure, important component. This is a very important component about the quality abortion care. You have to take care of the pain, reduce pain and anxiety, and make the woman comfortable. The two components of pain management include the non-pharmacological and pharmacological, where we use the medications. So the non-pharmacological pain management, this is regarding providing the psychological support, explaining each step to the woman in advance, what you are going to do, then performing the procedure gently and smoothly, and encouraging the woman to relax and breathe deeply. So you can call it vocal analgesia in your language, because the more you are interactive with the patient, the more you are gentle with the patient while talking to her, the more you're doing the procedure gently and smoothly, the more comfortable she is. So the pharmacological pain management, this includes the where to reduce the anxiety. We give anxiolytics in form of diazepam, or you can give her a general anesthesia. The dose of diazepam is 10 milligram orally 1 hour prior to the procedure, or 2 to 5 milligram IV 20 minutes prior to the procedure. The duration of effect is 4 to 6 hours. The side effects include disorientation and dizziness. Cervical dilatation, we can give at the time of cervical dilatation. This is most painful part of the procedure, and we can give a local anesthesia in form of lignocaine, which is 10 ml 1% lignocaine. Paracervical block can be given. Works for 60 to 90 minutes. And the side effects include dizziness, seizure, and gastritis. The analgesics, ibuprofen is preferred, 400 to 800 milligram, 1 hour prior to the procedure, and the duration of effect is 4 to 6 hours. If she is having uterine cramping, analgesics in form of ibuprofen, again 400 to 800 milligram, can be given 1 hour prior to the procedure and works for 4 to 8 hours. The complication side effect being gastritis. The steps of MVA. First of all, you have to prepare the instrument. You have to close the valve buttons and create a vacuum. This is a modified menstrual syringe type of thing. And the step 2 is prepare the woman. You ensure the pain control medication is being given at the appropriate time. Ask the woman to empty her bladder prior to the procedure. Perform a cervical antiseptic preparation. You have to buy betadine or any antiseptic like Savlon we used to before. Then administer a paracervical block. Positions being at 8 o'clock, 4 o'clock, 10 o'clock, and 8, 10, 4, and 2. Then dilate the cervix and insert the cannula. Suction of the uterine contents is done. Withdraw the cannula 1 to 2 centimeters away from the fundus inside the uterine cavity. Then rotate the cannula in 10 to 2 o'clock position with smooth, gentle motion and release the vacuum button on the aspirator. The signs of uterus, that it is empty. We all know we get a red or pink foam without the tissue passing through the cannula. We get a gritty sensation over the surface of the uterus, cervix dripping over the cannula, uterus contracting around the cannula, and increased uterine cramping. So whatever tissue you get, inspect the tissue for the villi. You come to know that you do have products of conception, because sometimes an ectopic might be there and people go for a evacuation method. You don't see the products, then you have to suspect. The concurrent procedures: proceed with contraception. Methods such as sterilization and ICT insertion. instrument person, which assists disinfection, helps remove tissue and body fluids. Post-procedure care, monitor her for any complications and provide management as needed. She may leave the facility only when she is stable and she meets the criteria of discharge. Ensure that the woman has all necessary information and medications prior leaving the facility. Document all outcomes of the treatment, including any adverse effects in the facility register and client record card. The aftercare includes management of abortion complications. If she is bleeding heavily, she's having fever, which says that she's having an incomplete abortion or she's having an infection, or if she doesn't bleed and she has an ongoing pregnancy, or sometimes she might bleed, but she still has an ongoing pregnancy. Then provision of contraceptive information and offer contraceptive counseling and methods. Assessment of any other sexual or reproductive health needs that may be required for additional care. The follow-up, again, no routine follow-up unless Misoprostol alone is given as a regimen. In summary, India has made historic progress in improving access to safe abortion. Not much has changed in the technological update in the last decade. As providers, it is up to us to ensure safety and equality, especially in context to the amended law. Along with safety, we all need to focus on respectful abortion services. This is the main part of the program which is being talked about. And every client, whether she is in public or she is in private hospital, you should always take an opportunity to inform her, to educate her, equip her with the proper information on contraception and counseling, and provide her a safe, dignified, and respectable abortion care. Thank you so much. So the next, do we have any questions?
Ma'am, questions can be answered in chat box. I think
Yes. So the next talk will be taken up by Dr. Kanchan, the most vital part of this program. She will be talking about safe abortion values, evidence, rights, and respect. That is the SAVOR module of WHO. Kanchan, Dr. Kanchan, the stage is yours.
Yes, thank you, ma'am. Are my slides visible?
Yes, yes.
Okay. Okay, good evening, everyone. So in module 3, I will be talking about the safe abortion values, evidences, right, and respect, the SAVOR module. Am I audible, Archana ma'am?
Yes, yes, yes.
Okay.
Very well.
Okay, the SAVOR module, and which is joint initiative by FOXI and WHO under respectful abortion care.
Slides are not moving, Dr. Kanchan.
Yes, ma'am. Okay. So this module will aim to define what is respectful abortion care according to WHO standards and highlights how norms and stigma affect services and provide WHO SAVOR resources for the respectful abortion care. So momentum has been created and law has changed, and we all know FOXI is the largest provider base for the abortion care, and online training is possible due to COVID situation, and so this respectful abortion care can reach to all the providers to the every corner. And so patient safety, respect, and quality matters more than ever, and we all have a role to play. So what is this respectful abortion care? According to WHO, it refers to care that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all type of abortion. In simpler terms, whether you are a provider or a patient, treat and are treated with dignity, empathy, and compassion regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history. I mean the number of previous pregnancies, number of previous miscarriages, abortion, or the relationship status. And if you ever feel that something isn't right, speak up. And as a health professional, it is our duty to listen and support, and effective communication is the key. So what are the norms and what are the stigmas? So here we have a very small video. And hope it plays.
It is not playing.
Yes, ma'am, let me fix it.
Social
Now
norms
it will
are
play.
unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change. Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. Behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin
and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
So we have 7 categories of disrespect and stigma. It can be physical abuse in form of slapping, intimidating physically, and verbal abuse, that is non-consented care, shouting, screaming, and sexual abuse, abuse of power, taking advantage. And every woman has right to freedom from harm and ill treatment, and right to information protection under law, that is Mtp and POCSO, informed consent and refusal, and respect for choices and preferences, dignity and quality of care. And the stigma and the other categories of disrespect are stigma and discrimination, which has been seen in the video, and failure to meet professional standards of care, poor rapport between women and provider, and health system conditions and constraints. And every woman has right to timely health care and to the highest attainable level of health liberty, autonomy, self-determination, and freedom from coercion. So what are the domains of respectful abortion cares? So WHO defines the 12 domains of respectful abortion care. That is being free from harm and mistreatment, and maintaining privacy and confidentiality of the woman, and preserving women's dignity, respecting women's choice, engaging with effective communication with the patient, between the patient and care provider, and providing information and seeking informed consent, and ensuring continuous access to support, enhancing the quality of physical environment and resources, and providing equitable abortion care, availability of competent and motivated providers, and also provision of contraception advices and commodity security, counseling of care and continuity of care and counseling. So pre-abortion, post-abortion counseling, this is very important aspect of this module and RAC, respectful abortion care. So it is time to strengthen the implementation, and we all know the important changes for the provider opinion. The every patient is an opportunity for the respect, and the providers, and as providers, the onus is on us to educate and also to reduce selective abortion. And up to, we all know, as previously discussed in the previous talks, that up to 20 weeks we need now 1 registered medical practitioner. So as a one provider, there is more responsibility regarding counseling and contraception and referral and compensate care. And up to from 20 to 24 weeks, there are 2 registered medical practitioners. Opinion of 2 registered medical practitioners are required, and these are usually special cases where, like the special categories where the patient is either rape or less than 18 years, and here the need for sensitivity and judgment free and timely services are required. So to provide the unbiased care, we need to overcome our own biases. And another changes, another most important point, the important point is the prioritize the confidentiality and safety. So name and other particulars of any woman seeking abortion is to be kept confidential, except to a person authorized in any law for the time being in force. And the grounds of failure of contraception, it has been extended to woman and her partner, whether married or unmarried. And what are the guides to avoiding stigmatizing languages? So we again have a video.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late, and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent Mtp Amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the Mtp Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework, but may be safe if performed by a trained provider or when a person has access to high-quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 Ps, provider, place, and process, are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high-quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified.
So WHO training for safer abortion values, evidences, and right. It engages and it explores and it informs and it equips. So from 1970, where this abortion were unsafe, the MTP Act in 1971 to 2000, where the abortion we talked about safe abortion, and now it is time 2020 where it is respectful abortion. So I'm playing one small game. We're giving questions to you, and I would request to write down answers in chat box. So according to WHO, restricting access reduces the number of unsafe abortion. So I would request you to write an answer in the chat box whether it is true or false. So answer is true. Many hesitant. It's true, true, true. So the question was, according to WHO, the Health Organization, WHO restricting. Wait a minute, I'm not able to visible my slides. Restricting access reduces the number of unsafe abortion. It is false. It does not reduce the number of restricting access will not reduce the number of unsafe abortion. So here we have discussed already that to meet the safe abortion, we need to fulfill both the criteria by appropriate method and by a trained person. And if we are lacking at any one of the criteria, then it is less safe. And if we lack at both the criteria, the abortion is unsafe. And now the next question is, according to Mtp Amendment 2021, it requires a minor less than 18 years to obtain written consent from parent or guardian before she can undergo a termination of pregnancy. So I want you to write the answer in chat box whether it is true or false. False, true. So here is that if a minor less than 18 years to obtain written consent from parent and guardian before she can undergo a termination of pregnancy, it is false, because according to new amendment 2021, she does not need, for abortion, she does not need the consent of parent or guardian. Anyone she trusts more than 18 years of age can give consent on her behalf for the abortion. Yes, we should not ignore here the POXO reporting. We need to do POXO reporting since he is a minor. We need to do POXO reporting. But for the abortion, we do not need parent or guardian's consent. Anyone more than 18 years of age whom she trusts can give consent for the termination of pregnancy. And here we need to provide bias-free services without any judgment. Now, this question is, a 30-year-old woman recently widowed want to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Is it yes or no? Someone has written no. Yes, no, no. Exactly. We as a provider, it is not our responsibility to guide to the patient and to tell her what to do, what to not do. It is her autonomy, it is her decision. We are there to provide the respectful services, not to take the decision on her behalf or not to guide her what to do and what to not do. So answer is no. So we have already discussed it, up to 20 weeks, 1 RMP, 20 to 24 weeks to register medical practitioner, and after 24 weeks, medical board, opinion of medical board is required. So in India, the abortion is legal. It was already legal. Let us make it safe and respectful. So Samarth, that is safe abortion, made available respectfully throughout health system, and make it a Samarth Bharat, Sampurn Bharat. Thank you.
Thank you so much, Kanchan, for the nice deliberation. And I think we need to talk about the 3 questions being discussed. Definitely, if WHO restricts abortion services, then more and more unsafe abortions will take place. So we cannot restrict the services, but it is all about providing safe services to the abortion seekers. And then regarding the minor, being given consent with the parents or the guardians. So Dr. Kanchan has already told, we don't need a guardian or a parent, just only a person who is more than 18 years old can give a consent. What we have to do is we have to just let the medical legal information given to the police in the POSCO Act. So thank you so much. And the last session is about counseling, pre and post abortion counseling, which no one should miss the opportunity, because women are most receptive at this time. So I would request now Dr. Poonam to come for the next session, and which is the last session. One thing I would like to say is please don't say a no, because even I was among one of them, and after this training I have realized this, because you never know under what condition is this person coming for you for an abortion, and if you refuse her an abortion, she might go into unsafe hands and might land up into complications and sometimes even mortality. So we have to provide safe abortion, respectable abortion, dignified abortion care to the females. So now I would request Dr. Kanchan, Dr. Poonam to give us, to enlighten us on pre and post abortion family planning counseling.
Good evening, everyone. I'm visible. Good evening, everyone. My thanks to Foxy and Heterogeneous for this wonderful initiation, and thanks for making me a part of it. I'm going to talk on pre and post abortion family planning counseling and how we can optimize the entire delivery system. So what's counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perception. So we see that each and every word in this definition has a meaning. A lot of have already been discussed so nicely and so well. Finally, the cornerstone of the entire respective abortion system forms the counseling. Counseling forms an integral part of the comprehensive abortive services. It is as important as the procedure. Women may need help in decision making, and whenever needed, the spouse should also be counseled. So how counseling helps? Counseling helps a woman to decide about the termination of pregnancy. Sometimes she's not able to decide whether she should terminate her pregnancy or not, or she should continue. So we help her to come out to that decision. It helps the woman to choose a method of termination, ensures a complete delivery or delivery of complete information about the procedure, and also helps the woman to adopt a contraceptive method to ensure her good term reproductive health. What are the basics of counseling? Basics of counseling lies in the privacy, sensitivity, simplicity, and assessment. Whereas where privacy and confidentiality is ensured by the law, the others are not. So we have to be non-judgmental, be sensitive, especially when we are dealing with unmarried and newly married females. We should not be very biased. We should try to maintain a rapport with the patient, and we should try to use simple language and allow the woman to clarify her doubts. And if she has still made up her mind for termination of pregnancy, assure her for the procedure. Relevance of peri-abortion counseling. Relevance, there is quick return to fertility, about 10 days or 2 weeks. And this time also forms an opportunity for the contraceptive advice, because at this time the patients are more receptive for this advice. And we should tell them that a minimum of 6 months gap is essential before she plans for the next pregnancy, and also about the health benefits and better future pregnancy outcomes. This is better for a family also. And as as said, that 90% of abortion-related maternal mortality can be prevented by ensuring contraception. So when should the counseling be started? Ideally, it should be started at the very first visit when the patient comes to you, and she wants to arrive at a decision. There are few exceptions, especially when the patient is not medically prepared to take the information that you are giving. So the importance of the counseling is the fact that there will be a return of fertility, which can be within 10 days or 2 weeks. Help her with choices. Then method specific counseling should be discussed, and high risk behavior should be discussed. Like in case of multiple partners, she should be advised to choose barrier contraceptive. And very important, if the woman is not willing to take up a contraceptive method, please don't refuse Mtp. Try to counsel her after the procedure. And if she's still not willing, call her for a follow-up after a week's time. Maybe she may be receptive at that time. What are the general guiding rules for contraception? First, we should ensure that the abortion process is complete. There is no complication. There is no existing infection. There is no injury to the genital organ. And definitely the chance of fresh pregnancy should be ruled out. What are the critical role for the post-procedure counseling is that ensures the woman has understood the precautions and the care needed during the post-abortive period, so that she can take care of her health, and an opportunity to counsel for contraception in case she has not previously accepted. It reinforces the need for continuing the use of contraceptive method which she has chosen. So we see that counseling is actually a continuous procedure, continuity, reassurance, and repeat. So this helps to build up a rapport which you have already developed with the patient, build up her confidence, and what you have told her is actually in her interest, and she can discuss this with her partner also, in case to avoid any future unplanned pregnancies. Reassure her that in case of any problem, you are always there to help her. Repeat the information about the post-procedure care and also the danger signs. So she should be intimated about the signs which she should report to you. So if the patient has already opted for any method, appreciate the fact that she has arrived at the decision. Start with immediate care, be it the IUCD or DMPA or pills, and a follow-up protocol should also be talked about. And if she has undecided, then you should take this time to allay her anxiety, talk and help her to make a choice, extend the period of adoption, and couple counseling is also important. And we can also talk about emergency pills at this time. So what are the various contraceptive methods? So there are barrier, hormonal, IUCDs. We all are aware of it. Just a quick review. Barrier method condoms, timing after first abortion. After first trimester abortion, it can be used as soon as the sexual activities resume. In second trimester also, as soon as the sexual activities resume. What are the benefits of barrier method? No hormonal side effects, can be used without consultation with health provider. They are easily available. It also prevents again sexually transmitted disease, and it enables the men to take their share of responsibilities. Intracontraceptive devices, IUCDs 380 and 3 days after the confirmation of completed abortion in surgical method, whereas in the medical method, inserted around 15 days of the process, provided complete expulsion of products is confirmed and the risk of infection and any other contraindication is ruled out. After second trimester abortion, they can be inserted immediately or up to 12 days after the procedure is complete, and definitely the contraindications need to be ruled out. The additional benefits are they are very highly effective, provides long-term contraception for 5 years or 10 years, and they can be provided by trained doctors, MBBS and above, ANMs, nurses after first trimester surgical abortion, and by trained doctors only after second trimester abortion. There's no interference in the sexual activity and immediate return to fertility after the removal, and no hormonal side effect. For hormonal contraceptions, we have many choices of combined oral contraceptive pills, and she can take it if she chooses for that. Oral contraceptives can be started immediately if after first trimester abortion, immediately or up to 7 days after abortion in surgical method. And with medical method, it can be started on day 3 with the dose of Mephibostone or within 15 days of the process after confirmation of completed abortion. At times, we should write these names, brand names on the discharge slip also, because in few cases, these patients actually never turn up. So if they have that brand written, they can take it by themselves. And after second trimester abortion, they can be started immediately or up to 7 days after abortion. The additional advantages are they regulate menstrual cycles, can be provided by all health workers after first screening by trained medical provider. There's no interference with sexual activity and offers protection against ectopic, endometrial ovarian carcinoma and benign diseases such as fibrocystic or fibroadenomatosis. However, they are not suitable for women who are breastfeeding, have babies less than 6 months old. For injectable contraceptions, we have medroxyprogesterone acetate. After first trimester abortion can be given immediately or up to 7 days after abortion using surgical method. With medical method, it can be started on day 3 with the dose of Misoprostol. And as we all know, given every 3 months subcute. However, limitations are unscheduled bleeding and delay of return to fertility. After second trimester abortion can be given immediately or up to 7 days after abortion. Additional is advantage, they are highly effective, confidential and privacy is maintained, can be provided by doctors, MBBS, Ayush and ANMs, nursing staff after screening by the doctors. For the first injection, no interference with sexual activity, no effect on quality of and quantity of milk. They don't have estrogenic side effects and offer protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. Finally, we have the permanent methods, which are sterilization, female sterilization or vasectomy. Can be after first trimester abortion, can be performed after an abortion in the absence of any infection or severe blood loss concurrently or up to 7 days. Both mini laparotomy and laparoscopic sterilization can be done. With medical method, it can be done only after the first menstrual cycle. After second trimester abortion, mini lap sterilization can be performed concurrently or up to 7 days after an abortion in absence of any severe or infection or blood loss. How definitely second trimester, after second trimester abortion, laparoscopic sterilization is not recommended. Advantage is that it gives a permanent method of contraception. It's highly effective, very low failure rates, effective immediately. There's no interference with sexual activity, no effects on breastfeeding, no long-term side effects, and offers protection against ovarian cancer. Vasectomy can be performed on males independent of the timing and the procedure of abortion, because the male partner takes part of it, and it's very effective. Permanent method, it's also a permanent method. There's no interference with sexual activity, no long-term health risks, and couples can use it together. This is the calendar form for various contraceptions. I'll just skip it out. Now, the role of teleconsultation in sexual and reproductive healthcare services. These days, as especially in the current COVID scenario, this teleconsultation has played a very vital role. So, providing services through teleconsultation, tele-counseling, tele-guidance, tele-reference, and tele-linkage. As about more than 80% people have smartphones, and people are using it. We have a website also, Hamdo. So there are social media, Ask Tanu, YouTube. They are solving contraceptive queries, infographics, helpline, and patient education platforms, WHO, Ministry of Health and Family Welfare, and RCOG. These are the different ways of actually reaching out to the people and giving them information about sexual and reproductive health care. What are the advantage of the teleconsultation? In COVID era, we all are aware how far it has helped. It's approachable, easily approachable, and throughout the process, privacy is maintained, awareness, spread out questions can be answered out at ease. But the weakness with teleconsultation lies that face-to-face interaction is missing and demonstration can't be done. Sometimes we are unable to convince the patient online. Opportunity is privacy and comfort, it's cost saving, and definitely cuts down the visit. Threat is diagnosis. Applicability of the component of CAC is assessment, confirmed diagnosis, contraceptive need, counseling, through video conference or Zoom, and follow-up. These days, forming a hybrid services. So the key message we all need realize the need of pre and post abortion family planning counseling. Bring the couple on board. Strive for 100% coverage. Capitalize on the basket and applicability in the post-abortion period. Technology, as far as possible, scope for entry in CSE service. Concern remains the policy, malpractice, service cost, and access. And adolescent reproductive health definitely needs to know both online and offline. So finally, in India, abortion is legal. Let us make it safe and respectful. Samarth Bharat, Sampoorn Bharat.
Thank you, Dr. Poolam, for this nice abortion care, counseling about the family planning, giving contraception, which is very important. So now we come to the end of this program, and which is regarding the safe, respectable abortion care. I wanted to talk a little about the privacy of the patient. That what we need to do is we don't have to mention the name of the patient on the files of the patients, because we have to maintain their privacy in all aspects. You have to give a number, whatever number you are providing to the patient, you just have to write the number of that file. Today only I got one patient who got a termination done for her congenital anomaly in Bombay. She had her own file, and on that file she had the number was name was not written. She was given a particular number. So this is what we have to do. We have to provide a number to the file, and not we don't have to write the name of the patient so as to maintain the privacy. So this is about respectable abortion care. We have to provide safe abortion services. Then we have to take care. At the same time, we have to see that new Mtp Amendment Act, wherever it is required, we have to take help of the nearby police station also in case of minors. And with documenting almost everything, I think we are safe, because sometimes we don't find ourselves safe, so we don't give services. The only thing is you have to document each and everything, and wherever it is required, you have to give it to the, you have to tell the nearby police station. So any other questions if are there?
There is one question, ma'am. If we write a number on file, then how we will maintain a record?
Inside you have the unique identifying number, and then you have your records along with in your software.
No,
Above the file,
one separate register should be maintained where the you can give that number. Separate register for all MTP, where the patient should be given that number.
that is on the file, wherever it can be seen, you don't have to write. Otherwise, you have to maintain all the records.
And there is one another question: how we will deny now to sex preferred abortion, as mostly are between 12 to 20. Oh God.
This is something which definitely people will like to take advantage of. And what you have to do is you have to keep the records, whatever she is saying that she has come for a contraception failure, because the most prominent part is that people try to say that it is a contraception failure, and they might be taking advantage of it. But then what you have to do is you have to keep the records, and you have to provide the services. What the government says is you don't say no.
ये कहना है कि जो गवर्नमेंट टीम आती है देखने के लिए, अभी थोड़े दिन पहले ही हमारे ही हॉस्पिटल में आई थी, वो इतनी बुरी तरह से करती है कि 12 से 20 हफ्तों के बीच वालों के लिए भी हम लोगों की ऐसी आफत कर दी कि लास्ट में उनको ये लिख के दिया कि मैं और डॉक्टर खरगोला साथ में मिलके करते हैं, ये भी नहीं कि खाली कंसल्ट है। तो जो हम लोगों के ये रिकॉर्ड्स वगैरह चेक करते हैं, वो तो जरा भी सेंसिटिव नहीं है, तो हम कैसे काम करेंगे? आप ये भी बताइए कि कैसे उन लोगों को सेंसिटिव बनाया जाए, जबकि हालांकि मैं भी उसमें रह चुकी हूँ, लेकिन मैं बता रही हूँ प्रॉब्लम आती है। अगर आप लोगों के भी रिकॉर्ड खंगालेंगे तो आपका सीधे दूसरे दिन अखबार में इतना बड़ा बड़ा नाम आएगा।
Ma'am, this is something I think we can give a letter to the CMO regarding this and the new MTP Amendment Act.
Yeah.
And
20 हफ्ते, अभी कुछ ही दिन पहले की बात है, अभी नहीं, अभी
yes, ma'am.
बात है, तो 12 से 20 हफ्ते।
Ma'am, I agree that sometimes the teams there.
तो ये तो देखना पड़ेगा कि कैसे एज ए प्राइवेट प्रैक्टिशनर कैसे काम करें।
हाँ मैम, ये बड़ा मुश्किल है. Even I had asked this question when I was attending my session.
Yeah, Dr. Archana, one thing more.
Dr. Ajay can answer something.
Yeah, okay.
Yeah, hi, good evening, everyone. Sorry, I have been terribly running late into several things. Yeah, hi, good to see you, Archana. Well done. Good program. Yeah. I hope everybody has had a good time in terms of understanding what's happening with the MTP issue. Whatever I could catch from what Geeta is saying, that the state authorities or the district authorities have been very severe in terms of collecting all the records and trying to push you to a corner. Is that what I understand?
Yes, yes.
Yeah. So see, भारत सरकार जब भी कुछ इशू करता है गाइडलाइंस, वो जब तक स्टेट आता है, जब तक डिस्ट्रिक्ट आता है, जब तक लोकल लेवल पे आता है, वो सालों निकल जाएंगे. Okay. And the whole issue now is that how what do we do in order to plug that hole?
Yeah.
The only thing that we can possibly do is to bring that bit of awareness amongst each one of you that the new laws have come in. So even if it has not trickled down to them, it is our duty then to tell them that these are the laws that have come into place. And this is the Ministry of Health and Family Welfare's directive. And this is what is there, and it is available on their website as well. So beyond that, there is not much that anyone else can do other than just keep informing them this is what it is. Now, there are several reasons and several motivations which the local authorities there will have to put you in the corner. Now, we will not get into those motivations of why they do it and how they do it and for what reason they do it. It's best known to them. Our only weapon is that there is a law, there is a rule which has been amended and which is in implementation phase right now. And we have to move with that. And we have to keep constantly alerting them and constantly confronting them that if you're following something as strict as what you're doing, then please follow the law as what has been prescribed by the Ministry of Health and Family Welfare.
Thank you, sir. Thank you so much, sir, for being there in the session.
Yeah, I just joined in, so I just couldn't, make it earlier. So I said before it closes, let me at least show my face. That and thank each and every one of you for making this happen. Yeah. Any other burning questions? Operational related, not the technical bit. Yeah.
Ritu, you had a question, I think.
SD, regarding SD, if patients comes after SD, then what to do?
If you sense it is an SD, just refer her to a government institute.
No, but that also, the question will still arise at government institute also, no? The government institute also cannot find out whether it is ST or not.
This is a very difficult question because many people, they definitely are taking advantage of this contraceptive failure asset. That's an asset for them.
Yeah, irrespective, the service has to be provided after making sure that you are protected in every which way. A lot of gray areas, and even when we talk of the having the medical board and all that, if 87% or 90% of vacancies are still there, how does the government start setting up the medical board? So those are the challenges also which are there. So the best course of action is to make sure if you have a government medical college and the medical college OBGYN department, the head of the department constitutes a medical board, and you can approach them, or you approach the magistrate for, or the patient along with you approaches the magistrate to get a favorable ruling in your favor to actually carry out the procedure that is required. Yeah.
So I think the more important is that you don't do sex determination. Providing a facility is, I think, not that questionable. But the thing questionable is that you don't do sex determination.
Yeah.
I think Dr. has a question.
I just want to ask that if the couple come for a termination of first pregnancy, then what should be our role?
Sorry, come again?
If a couple comes for termination of their first pregnancy, then what should be our role?
We have to provide them because we are not there to direct them whether to whether to
नहीं, but even law gives us certain indications ना कि when the MTP has to be performed. इसको mute करना.
Yeah, that has to fall into
and they just say नहीं, they just say that मेरा career है, अभी मुझे बच्चा नहीं करना, and they want to terminate their first pregnancy.
On demand तो नहीं है. You cannot do on demand MTP. You cannot do. What you says,
there are people
on demand MTP cannot do.
Then they have to say that it was a
contraceptive failure. Yes.
So there is a way and method for everything, and it can be done. I mean, at the end of the day, there's very little as service providers that we can do, except follow whatever is the law of the land and make sure you protect yourself. And that's the whole concept that we need to put forward to each one of you. I have posted in the chat box a link which will allow you to click on it and submit your post-test and feedback. Please do so that your entire program is complete and your training is complete with these 2 submissions also.
So we will also have to do that before.
We means the faculty doesn't have to do it. You have already done it when you became the faculty.
Yes, sir, we have done it.
Yeah. Rest everybody can.
Very simple and easy question.
Kanchan, I have a question. मेरा एक जगह थोड़ा सा कंफ्यूजन अभी भी है. अगर एक कोई गर्ल आती है, मोर देन 18 है, ठीक है, वी डोंट नीड एनी मतलब कंसेंट फ्रॉम हर पेरेंट्स, ठीक है. अगर माइनर आती है तो ये वाला कंफ्यूजन मेरा भी क्लियर नहीं हुआ है. माइनर के केस में तो हमें क्या, उसमें जैसे मैं पढ़ रही थी उसमें ये था कि माइनर के केस में तुम एक कोई भी रिस्पॉन्सिबल बंदा जो मोर देन 18 ईयर हो उसकी कंसेंट चल जाएगी.
नहीं, दैट बंदा शुड बी विद दैट गर्ल. दैट गर्ल ब्रिंग्स वन पर्सन मोर देन 18.
वो किसी को भी लेके आ जाए.
Yes, this is किसी को भी. But you are at the same time you are making PI also. Okay. And this is one gray area where वो किसी को भी लेके आ जाए जो भी है, but the law says that person is giving consent. Okay, signing the consent.
But so that problem is that in case of suppose ये केस चला जाता है, तुम्हारा रेप के केस में आ जाता है, then तो डॉक्टर पे भी तो ब्लेम आएगा कि उसने रेप का एविडेंस मिटा दिया.
No, you are doing at the same time PI आप भेज रहे हो ना, PI आप send कर रहे हो. You are not PI आप send कर रहे हो, at the same time you are giving the MTP care also, and that person who has come with that girl, that adult person, that is responsible. वो वहाँ sign दे रहा है. That according to new law, that he doesn't need to be parent or guardian, but he is an adult person.
हाँ, हमने PI करी तो हमें वेट करना पड़ेगा कि हम वो मतलब उस पे कोई एक्शन हो तभी हम करें.
No, you will start.
मतलब हम अबॉर्ट कर दें और PI का कोई भी. अच्छा, और अगर एक अनमैरिड मोर देन 18 आती है तो फिर कोई PI की जरूरत नहीं है.
No, फिर PI की जरूरत नहीं, obviously no. More than 18 years,
वो तो कह रहे उसमें आ जाएगी. बस मेरे को एक यहीं पे कंफ्यूजन बहुत हो रहा था कि ये कि कोई भी किसी को भी लेके आ जाए और उसको हम साइन कर दें. चलो ठीक है, थैंक यू.
But one thing I would if that is a medical abortion, then it's okay. But in case of if she needs surgical abortion, then it is always better to have any guardian, because surgical abortion, then consent will be about anesthesia and that also. Then it is always good to be on safe side. It always is good to call the parents on guardian. It is always.
अच्छा, और अगर हम मेडिकल अबॉर्शन दे रहे तो भी हमें PI करना पड़ेगा.
हाँ, less than 18 year comes under ये मतलब POCSO Act. You will have to send a PI.
Hello. Dr. Sama is asking if in every minor girl MTP we have to send PIL. Yes. Even if she is coming with the parent, it might be a case of incest. She is minor. You have to send a PIL. Then only you will provide the.
No, MTP even services. She comes with a parent also in case of minor. By definition or by law also, any minors, any sexual relationship minor comes under rape, sexual offense. So you will have to send a PI. अगर पेरेंट आते हैं तो भी, अगर पेरेंट मना करते हैं कि नहीं सेंड करो, बट पुलिस इन्फॉर्मेशन आपको एक फॉर योर सेफ्टी से बहुत सारे पेरेंट नहीं चाहते हैं, डोंट सेंड पीआई, बोलते नहीं ये पुलिस का ये नहीं चाहिए, बट एज अ डॉक्टर यू विल हैव टू सेंड वन पीआई एटलीस्ट दैट यू हैव इन्फॉर्म द पुलिस दैट वन माइनर हैज कम फॉर द अबॉर्शन. अगर आपने नहीं किया देन
I have a question.
हाँ.
Do we have to do any testing of the product of conception? अगर PI की बात है तो कल को DNA टेस्टिंग की बात आ जाए कि आपने प्रूफ मिटा दिया या DNA टेस्टिंग नहीं की तो?
I do not think we need to do it, ma'am. I do not think, because there will be ultrasound and there will be positive pregnancy test.
No. But if later on this case goes to court and they say कि less than 18 years थी, PI भी किया आपने, तो is it not our duty to do the DNA testing if later on this question arises? क्योंकि फिर तो प्रोडक्ट चला गया तो चला गया.
I think in that case, ma'am, then again the police will direct you. Police can direct it. We can intimate it to police. Do we need to do that? Let the responsibility lie on the police only.
Are there any guidelines कि ये case to case basis पे discuss होगा हर case पे?
I think a case to case basis होना चाहिए, and you can keep the product and communicate it with police only whether we need to keep it or not.
हाँ, वही तो मैं कह रही हूँ, ये केस टू केस बेसिस पे ही होगा ना, कोई गाइडलाइंस नहीं है इस पे.
कोई गाइडलाइंस नहीं.
अच्छा, एक क्वेश्चन और है मेरा कि हम जब वो फॉर्म भरते हैं तो उसमें ये होता है कि व्हाट कॉन्ट्रासेप्शन इज बीइंग यूज्ड आफ्टर एमटीपी. और नए गाइडलाइंस ये कह रहे हैं कि इट्स नॉट नेसेसरी कि आप कॉन्ट्रासेप्टिव पेशेंट उसी समय डिसाइड करे जब हम डीएनसी कर रहे हैं.
तो आप उस पे मेंशन कर दो कि contraception, she is not ready for contraception right now. She has been told after 1 week for counseling.
हाँ, ये हमें मेंशन करना होगा ना कि like patient is not ready or not accepted something.
Right now she is not ready and she is being again asked for a visit for contraceptive counseling. उसके बाद वो
हाँ, उसकी मर्जी तो है, लेकिन उस फॉर्म में हम ये लिख सकते हैं ना, फिर हम सारे फॉर्म में जैसे होता ही है कि आप सीओसीज लिख दो, ऐसे यू कैन राइट लाइक. तो क्या हमें ऐसे फॉलो अप में 1 हफ्ते बाद कुछ देना नहीं होगा कि हाँ 1 हफ्ते बाद उसने ये किया या नहीं किया टाइप्स?
If the person shows up for follow up, I'm sure the records will be available for you to make an entry.
That is what I'm asking, sir. If I am saying a patient is coming after 1 week for counseling, should I again rewrite that now the patient has opted for something?
Yeah. Update that with the correct date over there.
Okay.
I have by mistake posted the wrong post test, which was for the students of Dhira. Sriman has posted the correct one. So please click on the latest one in the chat box.
Title is clearly written there. Medical board will be district based or town wise. I think this is a state board.
Yeah, it will be a state board.
So I think we have come to the end of the session now, sir.
Yes.
Link has been provided again by Simran, and so this is the correct link as written by Ajay sir and also told here. So everyone has to go through this small post session test, I would say.
Yeah, post session test and the feedback. So please submit the same.
Please do that.
Yeah. So thank you very much, each one of you.
I think we can leave. Thank you, everyone. Thank you, Khurana ma'am. Thank you, Ajay sir, for being there to guide us.
All the best. Thank you, Sriman.
And thank you so much, all the delegates, for attending and giving time to us today.
Thank you so much, everyone, for coming and attending.
और इसमें पासी पड़े जा रहा है, पता नहीं क्या हो रहा है. शुगर तो नहीं होगी? नहीं, शुगर नहीं थी, वो भी चेक करा दिया मैंने. कब कराया? कल ही करा, परसों कराया था 84. अच्छा.